Thank you very, very much for that, that warm welcome, and I want to thank the Institute of Psychiatry for inviting me, and specifically Justin Baker. So starting off this panel, I'm actually not going to talk much about global mental health because I'm going to focus more on the technologies, but I think what you'll see is that a lot of what I'm going to say applies to, to the development of digital tools for a broad range of contexts. And the basic takeaway that I'm hoping that people take away is that we have to start changing our approaches if this is going to work. We need to start thinking more outside of the box, and I'll say a little bit more about that. Before I get started, I need to make my disclosures. I've taken consulting fees from Apple and Optum and One Mind Foundation, and some of the things I'm going to be talking about are licensed to Actualize Health, and I have an ownership interest in that. So I don't really need to go into this for this audience, but I'll be talking primarily about common mental health problems like depression and anxiety. And I want to make a distinction here between self-help and technology-enabled services. So there are around 10,000 apps up on the app stores, and I think of this as not unlike the self-help books that have been around. They may be helpful for people, but that I don't think is really going to be what changes mental health. That, digital technologies or technology-enabled services need to be embedded in our healthcare system in order to really have an impact on the populations that we care about. So that's really going to be the focus of this talk. Now we have had hundreds of randomized controlled trials that have really consistently shown that digital mental health tools are effective, and in particular, we see that when there's a coach or a human being attached, it improves outcomes, it improves engagement, and it's also important to note that these can be delivered by non-mental health professionals. In fact, one study out of Australia, the lay people had not significant, but a slightly better outcome than the mental health professionals. So these can task shift. These can be used to shift the task to other non-professional people. The problem is that every single instance that I'm aware of where we've tried to roll these out into healthcare settings, Kaiser Permanente and other large value-based care systems, they have repeatedly failed. There's not a single successful, and in Holland, for example, they're now spending 10% of their mental health budget on e-mental health, and it has not been successful to date outside of research settings or outside of research programs. So why are we seeing this large research to practice gap? I think that there are a number of reasons, but I'm going to focus on two here. One is that we've really failed to design for the patient, and we've failed to design for the care system. There are also issues in our research methodology that I won't go into, but I'm happy to talk with people about over the next couple of days. So let me focus first on the research design issue and present kind of an approach that we're taking that we think is one way of dealing with that. So what we've done up until now is we've designed to give people what we as clinicians think they should have, right? And this is the basic medical model. We try to get patients to do what we think they should. And the history is that, the internet has been, kind of ubiquitously available for a couple of decades now. And as soon as it became available, people like Greg Clark at Kaiser Permanente, Helen Christensen in Australia, Gerhard Andersson in Sweden, began looking at how we can digitize psychotherapy and get it out to people. And so the structure of a lot of these interventions looks a lot like psychotherapy. So there are, psychoeducational sessions often given once a week. People have to read or watch a video for 15 to 45 minutes. There are some interactive tools that kind of represent the worksheets that we often give patients. And then there's a coach or a therapist that tries to keep people engaged, and how that's defined varies. But these have been effective in efficacy trials, but they haven't translated. People have not used them in the real world. So how do we begin to get people to use it? Well, one thing, I think a first step is to understand what people are doing with technologies already in mental health. And so we've done a series of design studies where we've talked to people about how they're using technologies. And what we've seen consistently is that most people have tried digital mental health technologies, and they try them for a week or two and they don't like them. People don't like the things that we as clinicians have developed for them, but they are using technologies, and they're using them in bespoke ways. They're using a lot of different apps and tools. A lot of people are interested in behavioral tracking, sometimes it's as simple as they have a spreadsheet on their phone, and that allows them to do that. Menstrual tracking apps were used by a number of women, to kind of do planning. Most people don't want just mood tracking alone. You'll see almost every app for depression has mood tracking, and most people don't want that alone. They want it with something else. They're worried that if they have mood tracking, they're gonna, it's gonna kind of bum them out when they see they're getting worse. But they want to use the mood tracking to see how other things affect it, like having a period, or does sleep affect my mood? They do want information, and people vary in how much they want it. People really like daily tips, messaging. Social media, I'm not going to get into. There'll be something later, but that's a whole mess. There's it's a big benefit and a big problem. And in general, people use apps for a singular purpose. They don't use apps for lots of things. Think about like you use apps for transportation, for getting around, right? You don't have a transportation app on your phone. You've got an app that can find where to go to a restaurant. You've got an app for mapping out how to get there. You've probably got a few rideshare apps. I have an app for the Chicago Transit Authority on my phone. I've got plane apps. People use apps in small, for small individual purposes that they can access quickly. If an app takes more than 30 to 60 seconds or 90 seconds, it tends to get uninstalled pretty quickly. And they have to give something back to the user pretty quickly. So just giving data to your clinician is not going to keep people engaged, or putting in data and then in 2 weeks you're going to get something of value. So here's the challenge for mental health, for mental health and mobile applications. We have lots and lots of behavioral strategies, right? We have behavioral activation, cognitive restructuring, exercise is helpful, gratitude, relaxation, and so on. And there's lots of different features now that are available. So people read, or they watch videos. Messaging is the most popular activity on apps. Logging features, sensing. People increasingly are using images than the camera for a variety of purposes. So people use their phones in different ways. So how do we create something that is going to engage patients? So one of the directions that we've gone is what we call IntelliCare. And so what we've done here is create a suite of 13 intervention apps, and then at the top a hub app. And so each app is really simple to use, and it represents just one behavioral strategy. I'll show you a couple of examples in a second. But they're designed to go, to have quick use. We've got, involved users in the design. We've iterated over them. And so they're very elemental. People can pick and choose and use what's useful for them and not use what they don't like. They're mostly skills-based. So they're basically helping people do something that they want to do, and it's eclectic. It's not CBT or this or that. It's a bunch of behavioral strategies that people can use as they see fit. So this is one example of one of the more popular ones that we call Daily Feats. So all it does is when you download it, it asks you a question to peg your level of depression. And if you're really depressed, it gives you 4 things to do each day. Get out of bed, groom yourself, eat something, and get out of the house. And if you do that 4 or 5 days in a row, you get a streak and you level up. So there's a little gamification in there. And people seem to really like this. It takes a few seconds a day. It helps people organize their behavior. Day-to-day is the one that has some content in it, so there's a brief bit of content that gets launched every week, and just 4 or 5 pages on a phone, and then there are 4 or 5 messages that get sent out each day to remind people of the things that they learned through that little piece of content, and people really like the messages. This is a more traditional kind of approach for a thought record where people can enter the tools and then it populates the screen with the positive words. And then this is an image-based one where people can take a picture from their photo album or that they find on the internet and attach a mantra or an aphorism, and it'll launch periodically. So this is just some of the examples. They're just simple tools that people can use. So to date on Google Play, we've had about 120,000 downloads over the last couple of years. We currently have 10,000 active users. And if you use a benchmark that's been used before, so most people download apps and they look at it and they never use it again, right? So if you use a benchmark of using it 10 times or more, this one paper from Hellender for a health app, about 3% of users reach that criteria, and we're getting around 5 to 35% of people reaching that criteria. Across all the apps, they get used an average of 13 times over the course of a month, but there's a lot of variability there. So you can see that daily feats and day-to-day, the two that I said are most popular, they get used around 27 times over the course of about a month or a month and a half, from first to last use. And then there's some down at the bottom that are kind of our dogs. The bottom one we've actually pulled down because we can't fix it. So there's a range here in popularity. Oh, and I should also say that there's a hub app that if that's on the phone, it orchestrates across the suite. So it'll provide recommendations for new apps every week. It'll consolidate messages and so on. So we've been watching and sort of iterating based on what we saw on Google Play, and there's now some of these are up on iOS, and we've done a few trials. I'll describe first the one that we can present the data on right now is the first field trial where we enrolled 99 people who met criteria for depression or anxiety. Most had both, not surprisingly, and we entered them into an 8-week trial where a coach installed, not a mental health professional, just a BA level person, helped them install the Hub app on the phone and talked with them for about a half an hour. And then all of the messaging that was done after that was done via text messaging. So just 2 or 3 messages each week from the coach and some communication back and forth. And what you can see here is in the top panel, those little dots, those are the app launches. So the coach can see when the apps are being launched, which apps are being launched. On the right side is some information about the phone, so which apps are on the phone, which are currently recommended, and then a little bit of a place for notes. And then on the bottom is the tool to manage text messaging. And so in this first trial, we saw substantial reductions in both depression and anxiety. Viewed another way, those who were depressed, 37% met criteria for full remission, so a PHQ of less than 5 at the end of the 8 weeks. 40% were recovered, so a PHQ of 5 to 10, and 22% were still symptomatic, so above 10, and similar numbers for anxiety. So we were quite pleased with this, but what I was kind of more surprised about was this slide. So we looked at utilization, and for those of you who've seen these kinds of graphs for digital mental health tools, usually what you see is kind of a hockey stick, right? So, use starts out strong and then quickly drops off to a low level over the rest of it. And what we see here is that it stayed high throughout. So people launch these apps 3 or 4 times a day throughout the entire 8 weeks. And I think that there's a couple of reasons for that. One is that they were short. So the median time that people needed to use this was 17 seconds. And it's skewed a little bit because there's some relaxation apps that obviously take longer. But in general, it was short. People can fit it into the fabric of their lives. The second reason, I think, is this, and this is kind of messy, I know, so I'll walk you through it. So on the bottom here is the days in the study, and then the vertical axis here is number of apps on the phone. And so we didn't know whether people would install all the apps at once. A few people did, but mostly they kind of did what the Hub app was suggesting. Each week they installed another app or two. And so what we think is the other thing that keeps people engaged is novelty. So we know that most people say they only use an app for 1 or 2 weeks. So they get, so I'm getting a little stop sign here, so I'll speed through here. So novelty, I think, keeps people engaged. So I'm going to skip this. Just a little bit about design. And the other part of the design that I talked about is that we have to design for our healthcare systems. We see this, when these commercial tools get embedded in healthcare systems, they also don't work because they don't fit into people's workflows. You can't go into a healthcare system and ask somebody to do something new. People are already completely overburdened. If we don't make somebody's job easier, it's never going to get implemented. So we're beginning a lot of design work with Northwestern, the branch of Northwestern Medicine that is building out its value-based care. We're starting to do that with Rush in Medical Center. They've built out a collaborative care program. So we're working to try to design tools that fit into the healthcare system. That didn't go over well. And I think when we're designing this, we have to think about 3 things that people don't usually think about. First and foremost, we have to think about what is the service protocol. What we've done up until now is we design the technologies and then they don't really work, so we get humans to support them. And that's completely backwards. Technology should be supporting humans and not the other way around. So we need to define the service protocol first and then design the technologies to support those services. And then finally, we've completely ignored implementation plans, which are central to being able to get anything going. So just a little bit, this is I'll skip this, but there's the main thing that we found from these care managers, and these are care managers in Northwestern that are primarily for medical problems, but they have to give the PHQ, so they hate that because they can't do anything. In this care system, around the Chicago area, there's 4 to 6 month waiting lists. If they get outside of that, there's no mental health available, mental health care available. So they're really stuck. And what they talk about needing is being able to monitor the patients, because patients don't complete their PHQ-9s and then they have to chase them down. They need communication tools because nobody answers their phone anymore. So these care managers spend all of their time trying to get people on the phone. It's simple things. They need facilitation with medication management. They need alternatives to traditional care, which is largely unavailable, guidance and decision support, and program support. So we're currently completing a few trials. So one is through the company with the University of Arkansas, and then here at the Brigham. We're just about done. And the interim analyses as a controlled trials, and they look very positive. The randomized trial is looking at the role of coaching. And that actually is a failed trial that I think is really interesting. So coaching added nothing. Now I think that I don't believe that entirely. Because in research trials you get a more motivated group of people who agree to do all your research stuff. But it does suggest to me that if we can fit things into the fabric of people's lives and make it useful for them, they'll actually use it. And we don't have to cajole them and try to get them to use it. And then we're also starting collaborations with Rush to move into low-income communities in the Chicago area. So just to kind of start wrapping up, if we're going to move, I think the main message I want to get here, that probably I'm speaking to the choir, but if we're going to move from psychotherapy to digital mental health, I think this notion of a skeuomorph is useful. This is a design term that means here a derivative object that retains its design cues. So that's things like, in a chandelier, you sometimes see the light bulb is like a flame, right? And we haven't had candles in chandeliers for 150 years, but people like it. It's nice. E-books. They don't look like books, but it's helpful. to have them look. It's helpful to represent them as books. Some of them aren't helpful, like the record icon down there. That isn't used anymore, but nobody's seen a reel-to-reel. I mean, younger people haven't seen a reel-to-reel. Or this save icon. A colleague of mine told me about his son looking and finding one of those discs in his drawer and said, Daddy, somebody made a 3D printing of the save icon, right? So this is not going to be very long, and it could be around for very long. And so when we think about CBT or whatever, we're attaching the whole conceptualization of what we're doing to the past, and that's fine. That's worked well. Marshall McLuhan said the first iteration of any new medium imitates the one before it. But we have to move past it and begin thinking about new services, how services can be provided, how we can leverage technologies. So to summarize here, I think we have to design things to fit into the fabric of patients' lives. We have to meet the patient's needs and find the goals that line up with sort of our clinical goals to be able to get people, to help people do the things that they want to do. And we have to be able to fit into the workflows of providers. And I really want to emphasize this is a technology conference, but it's not about the technology. It's about the service. And the technology should be supporting that service, not the other way around. And finally, the approach that we're taking really is to use platforms. The nature of digital technologies is that we break them down into their smallest parts, and then people can bundle them as they need. And we need to stop thinking about an app for depression or for schizophrenia and start thinking about, what are the small components that can be delivered and people can assemble to help them with their lives. And then finally, a little plug. We have a postdoctoral fellowship that is co-training people in human-computer interaction and clinical science, and we're accepting applications. So if there's anybody looking for, or you have students looking for fellowships, we would welcome those. Thank you very much.